with us on time, and I really appreciate all of your presence today. So today is the day 2 of the 12th World Congress of Diabetes India, and I welcome you all virtually to Goa. And I'm quite happy and privileged to be chairing the first session. My co-chair is Dr. Rupam Chaudhary. He's here too. Hi,
Hello.
Dr. Rupam. He is a consultant diabetologist for Apollo Clinic in Guwahati. And this is me. I'm Dr. Dhruvi Hasnani. I'm a consultant diabetologist from Ahmedabad, from Rudraksh Institute of Medical Sciences. So without much ado, can I request Rupam sir to introduce our first speaker, Dr. Vijay Patni sir.
Welcome, Dr. Vijay Patni sir. This is a scientific extravaganza we are going through in these 3 days, and thanks to all the speakers and all eminent diabetologists who are joining us in this extravaganza. So I would like to invite Dr. Vijay Patni sir to deliver his talk.
So Dr. Vijay Patni sir is a consultant physician and cardiodiabetologist from Diabetes Wellness Clinic in Kolkata. He is also the founder of a very huge association called the Diabetes Research and Wellness Welfare Association. He has been a scientific chairperson to the 7th annual conference of DRWA 2019 and 2021 for Diabetes Update, and he has been a faculty and a scientist as well as an academician at multiple various national and international programs. So with that, if we have Dr. Rupam's permission, can we have Vijay Patni sir's slide, and can we request him to go on with the talk?
Yeah, sure.
Yeah. Can you allow me to share my screen?
RX team?
Sir, in downside, there is a green button. Yeah.
See the screen, please.
Yes.
Sir, it is not on slide. Yes, okay.
Thank you. Thank you, chairpersons. Thank you, my co-speakers, for giving me this opportunity, and thank you, Diabetes India as well. And we will be speaking on a very important topic, adjuvant therapies for type 1 diabetes, because that looks like a future. It's a known fact that the insulin remains the cornerstone of managing type 1 diabetes, in spite of various modifications, inventions, and formulations, along with the delivery techniques and monitoring techniques. We still are lacking. Lacking in what? We are unable to achieve the targeted glycemic targets like HbA1c or time in range. Along with that, because of this, most of our patients, majority of them probably, are having long-term complications. And insulin being the cornerstone, we are unable to address most of the issues. So the whole focus has now shifted to think something else away from insulin, so that whatever we can add to the therapy, so that we bring down the complications associated with type 1 diabetes. In doing so, basically, there are probably 3 major principles which need to be followed. And the first one, I would say, there's an obvious need to act fast, and so that we can reduce or prevent the beta cell destruction. The second principle, obviously, is to program or reprogram whatever beta cells is left, so that it is of a great use. And third one is to address the complication associated with type 1 diabetes. So keeping that in mind, I would proceed now. So basically, we are all aware that about 1.25 million people in the United States have type 1 diabetes, and we too have a huge population. We have a huge population of diabetes. So if you contribute even 5% of those population as type 1 diabetes, that comes to a huge number. All patients with type 1 diabetes requires insulin, but the issues are to intensify insulin to reach the target, and that remains the challenge. This is basically the timeline of various therapeutic discoveries in type 1 diabetes. and the future therapeutic development. As we all know, we are in the centenary year of insulin discovery, and thereafter we had huge number of modification in insulin. A huge number of modification insulin. Along with that, in the meanwhile, 2005, we got amylin analog, pramlintide approved. We had various immunomodulating drugs, cyclosporin and teplizumab. All these were there, but ultimately none of them have got the approval, excepting pramlintide, and probably we're looking towards sotagliflozin, which have already got approval in certain quarters. But then the future therapies, which one of my co-speaker will be speak on, the immunomodulating drugs or therapies, which might be the essential management tool which can address most of the issues with type 1 diabetes. So my agenda will be to speak first on the non-immunomodulatory molecules, and thereafter just touch upon some investigational agents and then the take-home message. So the first therapy, obviously insulin sensitizer, metformin, and all of you are aware that metformin is one such molecule which have some impact on insulin resistance and decrease the hepatic gluconeogenesis, but still has not been approved by type 1 diabetes, though it has made in various studies, has shown some kind of influence as far as the HbA1c reduction, weight loss, or even in decrease in the insulin dosage is concerned. Two randomized control trials, which we are looking forward, removal, which is already published, and Emerald as well. So what we saw in this particular systemic review of efficacy, this was basically when they gathered about 197 studies of which various trials, and then they looked into the efficacy part, and they could deduce that metformin was associated with reduction in insulin dose requirement, even in HbA1c, even in weight, and some small reduction in total cholesterol. So adding metformin to insulin therapy may reduce insulin requirements. This is what ADA says, and improve the metabolic control in overweight, obese patients and poorly controlled adolescents with type 1 diabetes. So this is what we are expecting that metformin to do, but still the approval is awaited and has not been advocated for use. And this is the removal trial, which was the cardiovascular metabolic effect of metformin. Unfortunately, it could not
Recording in progress.
Is no more there. There's a package insert which says it should not be used in the treatment of type 1 diabetes. The third such molecule which is of importance, that is the pramlintide, is the amylin analog. Basically, type 1 diabetes patients are deficit in amylin, and this is the reason why this was tried, and it has somehow achieved little bit of impact, but not to that extent. It basically delays the gastric emptying, blunts the pancreatic secretion of the glucagon. These are all CNS modulated and enhances the satiety as well. So the major impact is on the postprandial sugars, and the side effects are profound. So because of the increase in number of injections to be given in a day to control the prandial sugar, along with the side effect profile, probably it is not able to address the major issues, though it has good efficacy of reduction of about 0.3 to 0.4% of HbA1c, and does induce weight loss. and lower the insulin dosage. So it has been considered as adjunctive therapy approved in particular in the US in type 1 diabetes patients who have failed to achieve the glycemic goal. Next, we come to the alpha glucosidase inhibitors, acarbose. Now, acarbose was studied, and basically what they realized that it does reduce as expected the postprandial plasma glucose levels, but there was no significant effect of HbA1c, and the long-term benefit was not seen, though the safety and tolerability was not that a great issue. It was reasonably safe, but yes, the GI effects were much more. The next important therapy is the incretin based therapy, and all the eyes probably on this non-immunomodulatory drug group is this particular molecule, that is the GLP-1 receptor agonist, and the mechanism which helps in having an impact little, not only on the insulin secretory impact, but it has its own other mechanism which can almost address 6 of the 8 pathophysiological mechanisms responsible for diabetes, but that's more in type 2 diabetes. So what we see out here, they do delay the gastric emptying, they suppress the postprandial glucagon rise, increase the satiety, and facilitate weight loss. So it acts as an adjunct to the insulin. Could be a great molecule, but has not been approved by FDA yet. And this was the study, and where a total of 9 clinical trials was reported. It was considered in overweight or obese patient, though not at glycemic goal. The molecule used was liraglutide, and this was the only molecule which had the strongest evidence as far as this group of drug being used in type 1 diabetes. The effect on HbA1c was inconsistent, but reasonably it showed some impact. Along with that, it showed lowering of the dosage of insulin along with the postprandial blood sugar control. But the adverse events was in population was intolerable, and mainly it was GI side effects. So this particular paper has actually looked into the meta-analysis of 3 RCTs, and they concluded that the HbA1c was reduced to about 0.3%, and both the basal as well as the bolus doses was reasonably reduced, along with a huge impact on the body weight. Though there was an increase in the risk of nausea, but did not increase vomiting. And there was a 2 such trial, adjunct trial, that was trial 1 and trial 2, which concluded that this is a molecule which has shown some promise and could be further studies are needed so that we can really include this molecule in the armamentarium of type 1 diabetes. And in that particular study, it was shown that it doesn't increase the DKA as well. So basically, what is more important is the mouse or the animal model where actually it showed that it increases the beta cell proliferation, increase in beta cell differentiation, decreasing the rate of beta cell apoptosis. This gives us a hope, basically, that this GLP-1 receptor agonist could be a molecule of future for type 1 diabetes, as and when it is approved and when large studies are done with it, so that we get a better outlook as far as this particular molecule is concerned. Now, DPP-4, it doesn't show much promise, has not been improved by FDA. There was various meta-analysis of various trials was done, but it doesn't have much of impact on HbA1c, neither it increases the fasting C-peptide level. So probably this molecule doesn't show much of a hope. SGLT2 inhibitor, because it is insulin independent glucose lowering agent. So this was one particular molecule which was thought about, and along with not only the blood glucose lowering impact, it has other impact like lowering the blood pressure, lowering the weight reduction property was there, but the limitation was the diabetic ketoacidosis. So presently, SGLT2 inhibitors are not recommended, but we have this particular molecule, which is the dual SGLT2 inhibition, sotagliflozin, which is approved in use of type 1 diabetes, though not universally. And these are the various trials which has undergone with SGLT2 in type 1 diabetes patient. It was the DEPIC trial, dapagliflozin, empagliflozin, East trial. East trial really showed some some kind of I would say the conclusion was that if you do use a very low dose of empagliflozin to the tune of 2.5 milligram, probably the episodes of decay are taken care of. There were not so many patients, so many episodes of diabetic ketoacidosis. So that's a one good point. But Tandem has put sotagliflozin high above these two SGLT inhibitors, and this has been the present approved molecule in certain quarters. But the one important thing is that this should be done under surveillance, under vigilance, and one should be aware of ketoacidosis, and then only this molecule should be used, though I know this is being used off-label in certain quarters. So important points of this particular talk is most patients with type 1 diabetes on exogenous insulin injection do not achieve the glycemic goals. Exogenous insulin treatment has limitation, including insulin-related weight gain and recurrent hypoglycemia. Almost all patients with type 1 diabetes have inappropriately high glucagon level, which contribute to hyperglycemia, and reduced insulin sensitivity increases the insulin dose requirement. And these are the various, I think, the conclusion on various molecules which we already discussed, and the only promising molecule of which of the approved molecules happens to be a myelin agonist. And along with that, we are looking forward to GLP-1 receptor agonists and the dual SGL2 and SGLT1 inhibitors. So the dual blockade SGL2 inhibitors would probably, SGL2 inhibitors might be one such molecular group which can come in a long way, because there are other molecules apart from sotagliflozin which are looked into. So according to ADA, the GLP-1 agonist DPP-4 and SGL2 are maybe the potential therapies, but do require large clinical trials. US FDA have clearly said the metformin, SGL2, GLP-1, DPP-4 are not FDA approved for the treatment of type 1 diabetes in the United States. Now, this I'm just going to touch because the whole talk will be taken over by my co-speaker. The immune-focused therapy, probably they are the future, though they have not yet shown that much of a conclusion as far as the as a great kind of adjuvant therapy for type 1 diabetes. But if you look at the pathophysiology, there are predisposing factors over and above. If a trigger is there, like infection, these unhealthy beta cells which are there in this group of population, they actually undergo auto-antigen recognition, which lead to beta cell destruction, what we call assist suicide. So, this particular beta cell destruction will lead to all the metabolic derangement and complications, and ultimately to increased mortality. The conventional theory was that the major reason behind this type 1 diabetes was dysfunctional immune system, that is the imbalance between autoreactive T effector cells and T regulatory cells. So the various molecules which can act at these various levels can be of benefit in future as an adjuvant therapy for type 1 diabetes. If you look at the beta cell areas, or at the local action at the beta cells, probably the antigenic immunization or tolerization with oral insulin peptide could be one such therapy. The stress relief, which we have seen with GLP-1 receptor agonist and verapamil, or the stimulating remaining cell mass, that is the GLP-1 receptor agonist, as I addressed, which are the three major principles. One or two principles are implied here. And then the systemic approach to actually look into the dysfunctional immune system, whether it's targeted immunomodulation with cytokine blockade, or immune suppression, or T regulatory cell expansion. These all can be of importance if further studies are done down the line. But present scenario, which we have the non-immunomodulatory drugs, like which can address not only the metabolic derangement as well as the complications, and they probably should be looked into. Particularly, focus should have been on the GLP-1 receptor agonists and dual SGL2 blockade. That could give us an insight into the particular additional therapies which we can employ in type 1 diabetes along with insulin. And obviously the curative treatment on the horizon happens to be stem cell therapy, and we hope that will be taken care of very soon. But unfortunately, that is also going to be an issue of autoimmune destruction in those patients who receive cells stem cell therapy as well, until a proper immunomodulation is done in those cases as well. I think I will leave it here rather than going into the further into the immune-focused therapies, because my co-speaker will be dwelling on that, and I don't want it to be a repetition. So to take home message from my side would be insulin still remains at the cornerstones. Pramlintide has been approved, but there are issues with it. Very difficult to use them in day-to-day practice. Metformin, debatable, but has shown benefits. Pioglitazone and rosiglitazone probably out of tune. And GLP-1 agonist, DPP-4 SGLT inhibitors need to be looked into with larger clinical trial, could be a potential therapy for type 1 diabetes. And sotagliflozin is the first approved oral medication for type 1 diabetes to reach the market. And obviously the investigational agents or the futuristic or the immunotherapy-based molecules looks to be the future in type 1 diabetes. Thank you. I'll stop sharing. Yes, please.
Thank you, Vijay sir, for your excellent deliberation. It is unfortunate that despite all those basal bolus therapies we give to our type 1 patients, more than 50% of our patients does not reach their glycemic target or optimum HbA1c. So one question, sir, I mean, have you come across any DKA cases or any metabolic acidosis with the use of SGLT2 off-label, of course, in your patients?
No, I have not used SGLT2 inhibitors in type 1 diabetes patient, but with the use of SGLT2 in type 2 diabetes, I have come across to euglycemic DKA in certain group of patients.
Dr. Dhruvi, if we have any questions?
I think I'm sorry, I'll have to prompt you guys here that we have a separate discussion segment at the end of the session, and if you all agree, let us dedicate that time to discussion at that point of time. And let's just move ahead to our next speaker, Dr. Barkay Laszlo. Okay, it's the other way around. All right, it's Dr. Laszlo Barkay, and he's a professor pediatrics at Safarek University in Kosais, if I'm pronouncing it right. And he is the Theoretical Health Sciences Professor and Head of Institute for the Theoretical Health Sciences, University of Moscow, and he's been the past president for Hungarian Diabetes Association. I'm sorry if I have had, mispronounced something. Over to you, Dr. Barkay.
Okay. Thank you very much. I'll try to share my slides with you. Just a moment. Okay. Can you see my slides?
Yes, sir.
Okay. Thank you very much. It's my great pleasure. Sorry. Is it okay to see?
Yes.
Good. So thank you very much, first of all, for my kind invitation from the organizers of Diabetes India, especially to my friend Banshi Shabu. And I'm really happy to share my thoughts in this audience. So let me start with this big trial. This is a type 1 diabetes exchange program in the United States, and clearly showed that during the past years, there is an increasing rate of use of new technologies, and that means the pump and CGM systems. But as you can see on the lower panel on the left, the global glycemic control of the patients did not improve during this period. If we look at the 2016 to 18 period and compare the results to the 2010 to 12, the glycemic control expressed by A1C was poorer in the later years as compared to the former. And actually, the problem is that especially in youth, children, adolescents, and young adults showed the poorest results. The good news can be seen on the left or the right side. Those patients who used pump and CGM together had the best A1C levels in all age categories. So
Can I interrupt you a second? Could you put this
Yeah.
on slide mode, please?
Sorry?
Could you put it on a slideshow mode, please? The slides are in a simple slide mode. If you can put it in the slideshow.
Yes, I'm not able to clear. You know, there are the pictures from the camera on the right side.
Okay.
How can I?
Could you just try and discontinue sharing once and try sharing it once again?
Okay.
Yeah, that could be a simplest answer.
Just a moment. Okay.
RX team, can we could.
Clinical target achievements. So we have good delivery systems nowadays and good monitoring systems. For delivery of insulin, we use pens and pumps, and for monitoring the capillary glucose measurement or the interstitial glucose. The pump and interstitial glucose devices are able to provide a so-called automated insulin delivery. Of course, this should be in conjunction with data management. Continuous subcutaneous insulin infusion and real-time glucose monitoring is really a good choice and gave a big advantage regarding optimal therapy adjustments. However, we have limitation because using these devices, using these methodologies, these are time-consuming for reviewing data. So what is the possibility? We have to close or put closer these two devices, a connection between the pump and the CGM, and on the right side can be seen the closed loop system sensing the glucose level and using a modulation and insulin delivery is driven, and the glucose control is possibly improved. The brain of the system is, of course, the control algorithm. Nowadays, on the clinical practice, in the market, we have the so-called open loop system, which is a sensor augmented pump, which is totally dependent on user input. However, there are three very good functions. The threshold suspend function, which means that insulin can be suspended when glucose level is dropping. The predictive glucose, low glucose suspend means that insulin will be stopped when the glucose decline is predicted. The high glucose minimizer means that the insulin delivery will be increased or activated when glucose level is increasing or predicted to increase. The hybrid closed loop system, more advanced technology, using continuous basal rate adjustment in response to glycemic trends, but this still requires user inputs like carbohydrate intake or so on. And the future would be the fully closed loop system, the artificial pancreas, which could be not dependent, absolutely independent on user inputs. One assumption is that the bihormonal artificial pancreas, which uses not just insulin, but an additional hormone, most commonly glucagon. We have to mention the do-it-yourself devices, which are community-developed devices, and these communities are applying these systems. We have to state that these systems are not approved by the authorities. How this hybrid closed-loop system is working, as you can see, the patient should input the carbohydrate intake. Meanwhile, the glucose level is measured. Actually, the lower panel shows that using a continuous glucose, continuous insulin delivery, sometimes the patient needs to give bolus insulin. So, however, as this big randomized trial in children with type 1 diabetes showed that the hybrid closed-loop system is working much better as compared to the older one, the sensor-augmented pump. Looking at the slide showing that this 4 months trial, the glucose level was much longer time, significantly longer time in the target range using hybrid closed loop system as compared to the sensor augmented pump. So the problem with these systems is that either the monitoring or insulin delivery currently uses the subcutaneous tissue, and this is non-physiological. We would like to use the intravascular compartment to monitor the glucose and to deliver the insulin in this area. That's why there is a big research drive towards the implantable artificial pancreas, which is a big issue. Just an example, using a spectroscopy method to measure the blood glucose in the microvessels, using the nail bed, which is quite rich of capillaries. This could be used for non-invasive and quite accurate measurement of intravascular blood glucose level. However, this is understandably far from the clinical practice. Another approach, how can we implant insulin pump? This is one assumption published in the Science Robotics recently. An implantable pump could be placed into retroperitoneal tissue, and the capsule swollen by the patient contains the insulin, and the capsule can be docked at the pump level and deliver the insulin content into the pump, and the insulin will be finally delivered to the peritoneal cavity. I have not to emphasize that this is still far from the clinical practice. If we have a new systems, of course, we need new indicators as well. It's absolutely well known that if we have 3 patients exactly with the same A1C level, there could be a big difference or big differences between the glycemic control regarding the swings, the glycemic variability. If we use just self-monitoring capillary blood glucose measurements, we will not able to capture these swings. If we use the CGM, we can realize that how big is the glycemic control, the glycemic variability. Some recommendations came out from the literature. This is one of the latest one. This is the international consensus. And this consensus pointed out that the clinical utilization of CGM results are still suboptimal. We have a huge number of data, and we have to handle them. And this is really difficult to understand what can we do with them. It's time consuming. In some countries, there are reimbursement problems with using CGM, and there is some kind of lack of standardization of data and lack of visualization. Okay, this recommendation highlighted the use of a simple parameter, simple method to check the glycemic control from CGM data. And this is now has been introduced into the clinical practice, the time in range parameter, which means that how long time of the glucose level spent in the target range. Target range is recommended 3.9 to 10 millimole per liter. Above this range, hyperglycemic, and below the range, the hypoglycemic ranges. The better the control. If the time in range is longer or bigger or higher, and the better the control if the hyperglycemic or hypoglycemic time and measurements are smaller. Another parameters, the glucose management indicator. From this big number of CGM data, we can have an estimation. We can make an estimation of central laboratory A1C level, because there is a quite strong and significant correlation we can use to estimate the A1C level from CGM data. Nowadays, the recommended parameters, of course, the average glucose level is understandably, and the so-called GMI, which is the estimated A1C level, should be below 7%, and glycemic variability, which is the percent of coefficient of variation of the glucose, is less than 36%, and time in range, it's better if it is over 70%. However, these parameters usefulness will be shown if the clinical indicators could be improved by the use of these parameters like hypoglycemia or late complications, cognitive function, or quality of life. Another recommendation is that the standardized reports and ambulatory glucose profile should be provided for the patient and for the doctors as well to visualize and interpret data. And nowadays, most of the companies are using and accepting these recommendations. Finally, these new parameters. How can we be sure that these markers are valid with regard to late complications? Could these parameters surrogate markers for complications? This summary, this recent paper summarized this concept from some literature research data and showed that the increase of the time in range will result in a decrease in microalbuminuria frequency and retinopathy rate. So it seems to be that these new parameters are working and hopefully will be really useful in the future perspective of our patients. So in conclusions, dear colleagues, I would like to emphasize that current technologies improve type 1 diabetes management, but the biggest barriers are the non-physiological glucose monitoring and insulin delivery. The new indicators of glucose metrics should be considered nowadays in the clinical practice, and standardized report on ambulatory glucose profile is needed to help to understand the results. And further research will be established the long-term benefits of emerging technologies and new indicators of glycemic control. And let me to finish my talk and thank you for your attention with this slide, with this picture, when our old friend Shaukat Shadikot, who was actually the founder of Diabetes India, he was still with us at that time, but now we are really missing him from Diabetes India. Thank you very much.
Thank you, Dr. Barkay. It was an excellent presentation. Thanks for your insight on this topic. So, Dr. Ruby, I think next speaker is ready. We have Dr. Stephen Green from UK.
RX team, can we please have his introduction slide? Thank you. Dr. Rupam?
Yeah, we have our next speaker, Dr. Stephen. He is from UK and he's a consultant diabetologist for children, adolescents, and young adults at London. He's president of International Society for Pediatric and Adolescent Diabetes, also known as ISPAD. And his tenure was from 2012 to 2016, and he's currently a director of Scottish Children Research Network. So I would like to invite Dr. Stephen for his deliberation.
Okay, thank you. So just before we start, can I check, can you hear me okay? Yeah?
Yes, we can. Yes.
I've had some problems with my sound on my computer, so sorry about that. Right, so I'm going to try and share my screen now. And okay, there we go, and we'll put on that. Right, okay, so I was very grateful for Dr. Patney for setting me up there. It was very good. I could have gone off and had a cup of coffee, because you've given the lecture, which is fine. But I'm going to actually approach this slightly differently. I'm not an immunologist. That's number one. Absolutely not an immunologist. I'm not even sure I understand a lot of immunology. And secondly, although I have been involved in the prevention studies over the years as a participant, and actually instigated one of them, I'm not currently involved in any prevention studies. So I'm actually coming at this from a pediatrician involved with families and young people with diabetes. And in a sense, the way I've approached it is because one of the commoner questions that is being asked all the time now when people come along to the clinic when they've first been diagnosed is, can you cure diabetes? It's perhaps been a common question that's always been there in patients' mind, but there's more and more information coming out, particularly through internet sites, patient associations, charities, etc. And so parents come along with a lot of questions around that whole idea that they should be able to do something to prevent or ameliorate the diabetes. And that's what I'm going to concentrate on in this talk. I'm also going to concentrate on, I just need to change the view here a minute. Oh, sorry. How do I change the? Oh, I'll leave it. I'm also going to concentrate on immunotherapy, biological therapy. I'm not going to say anything of any detail about stem cell therapy or islet cell transplants, which you could argue comes under immunotherapy, but I'm going to, as I say, strictly concentrating onto the biological sort of approach for immunotherapy. And there's all sorts of things that have been thought of and being used. I mean, this is where my lack of immunology training comes in. How all of these work, how they're set up, how they're established is really something for the expert. It's a minefield of areas in which to do. But fair to say that virtually all of these have been looked at in the approach to treating diabetes. And I think it's fair to say over the last 30, 40 years, most of them, virtually all of them, have turned out to be ineffective. So many of us who've been around for a while remember the initial excitement over cyclosporin as a immunosuppressant, azathioprine, then moving on to nicotinamide, and these drugs were thought to be very exciting at the time and really proved nothing. And then we've come more into the biological ages and particularly the monoclonal antibodies. So I'm going to talk a little bit about those in depth at the moment. What's gone wrong here? Oh, there we are. Now, this is my simplistic view of the autoimmunity of type 1 diabetes. The point I want to make about here is that we still haven't identified if there is an antigen which sets the whole process off. People are constantly looking for this. Still interest in virus stimulation. Is it dietary? Is it an environmental stimulus? We don't know. So we don't know whether there is actually an antigen which sets the whole thing off. What we do know that there is some genetic component to this with the MHC compatibility, HLA system, which triggers, combined with an antigen, triggers this process, which then very rapidly turns on itself through the T cell damage and the effector white cells, and eventually leads to this vicious circle of destruction of the beta cell. And the autoantibodies are a probable consequence of all of this destruction and leading to the apoptosis and necrosis of the beta cell. So there's all various ways in which you can try and alter this process. The point though about that process is in this graph, and I'm going to spend most of the time in the next 10 minutes or 5 minutes, 5 to 10 minutes, talking about the disease progression and how you can alter it. So I think this is the current acceptable scheme of how type 1 diabetes presents. And in a sense, what we've got is, as clinicians, we're here at the bottom end of the program, where you've got symptomatic type 1 diabetes. And what you've got is you've got beta cell autoimmunity, because you've got lots of antibodies around. You've got beta cell loss. So in some of the very few studies that have been done, you can show that there's a really significant insulinitis and a loss of beta cell presenting cells. There's hyperglycemia and symptoms are present. And this is called stage 3. And that's the clinical presentation of type 1 diabetes. Stage 2 is the stage earlier, which is where you've got antibodies present and you've got some beta cell loss and you've got a little bit of dysglycemia. I think that's the term which is being used more and more. But basically, you've got probably expressed in that, which is that you've got a poor response to an oral glucose tolerance test, but you haven't really got any symptoms. You haven't got the weight loss. You haven't got the ketosis, and the child is very well. So this is what used to be called the prodromal phase, the stage 2 that you get many months. And we know from many studies, sort of like the very old box study in the UK, that this could be going on for not just months, but actually years, which is often quite a shock to parents. And then you've got stage 1, where really, again, no symptoms. You haven't got any suggestion that you've got abnormal glucose levels, but you have got beta cell loss, and you have got the developing beta cell autoimmunity. And then there's this curiously labeled stage called pre-stage 1, where in fact you haven't got any of these factors other than some risk factors. And these are very poorly defined at the moment. You've got a family history of diabetes, and you may well have some presence of biomarkers such as the HLA gene system. But in a sense, that pre-stage 1 is one which is poorly defined at the present time. So let's just dissect these at the moment and in a sense go through them as to where these stages, what are the opportunities in these stages for immunotherapy, and what are the difficulties confronting people for immunotherapy. So in pre-stage 1, over here on this stage here, you've got the risk of diabetes. You've got the possible genetic susceptibility. But as I said, there are no antibodies present. You've possibly got first-degree relatives. Now, people quote up to 20%, but it's never any more than that. And I always, at this point, raise the issue that type 2 diabetes is possibly a more genetic linked disease than type 1. And you've got this varying progression to clinical type 1. So one of the points about this is that although you've got the schema at the top with that curve, for some people, this may be a very sharp decline. And for some people, it's a very, very long decline. So that's why you get type 1 diabetes presenting very rapidly in young children with this rapid progression to beta cell apoptosis and destruction, whereas in some people, it goes on for years and years and years. And we have no biomarker which actually predicts that varying progression to clinical type 1. To do any studies in this arena, you have to look at population screening. And as I say, it's difficult to pick these out. But even if you go on to the next stage, which we'll do in a second, population screening is going to pick out a very, very small number of at-risk patients. So there's the whole aspect of setting up population screening. How do you do it? And the costs of doing that, and the simplicity and the efficacy and the effectiveness of that. So we've got a real problem here that in a sense, stage 1 is a difficult stage to work with. The problem is that if theoretically this is the stage at which immunotherapy is likely to be most successful, because you're going to be hitting the immune process before it's got into that really strong vicious cycle element of production of the antibodies and of the destruction of the cell. And it may be a simplistic thing of removing the antibody, if it is simple, or stopping the antibodies being attacked through the HLA system and the MRC system. So it's a real paradox that the area where we would like to work with is the most difficult to pick out the patients. You move on to stage 1 and stage 2. So here we've got stage 1 where you've got autoimmunity with normal glycemia, and stage 2 is autoimmunity with dysglycemia. You've got positive antibodies in both of them. You've got high lifetime risk of type 1 diabetes, so it's important to recognize this. So once you get into these 2 stages, your progression to type 1 diabetes is very strong. But as I mentioned in both of them, it's a variable progression. And that's something that has to be taken into account when you look at trial data. You get antigen presentation, T cell activation, plasma cell formation, and pancreatic insulitis, and that leads to the dysglycemia, the inability to handle food properly, and high baseline blood glucoses. So this then raises another question in these 2 groups. What is immunotherapy for? Is it to actually stop the process, or is it aimed to risk or reduce or double the time of diagnosis by 50%? So in other words, are you looking at the absolute stopping of the diabetes or slowing its progression? Finally, you move on to stage 3, which is the clinical side. So here we've got clinical diabetes. We think that the beta cell mass loss is down to about 90% in these cases. Difficult to work that one out, but that's probably about right. And again, are we looking here at preservation of beta cell function and looking at things like C-peptide or possibly other biomarkers of the immune process? And how valuable is this if we do that? Are we aiming for a cure? That's probably unlikely at this stage. Or are we looking at amelioration of the diabetes? In other words, you make diabetes management easier. And finally, we've got to weigh up all of this against the clinical diabetes. Are we looking at prevention versus management? And as Dr. Patini and Dr. Laszlo pointed out, we've got developing very good treatments for clinical diabetes. You optimize the insulin therapy, you put people on continuous glucose monitors, you give them insulin pumps and closed loop systems, and possibly the missing factor to try and get this to work is really large amounts of support in all sorts of ways, behavioral, social, etc. So we've got a situation where we've got to weigh up the immune therapy. How effective is it likely to be? What's our gain going to be? And how does it compare with the current sorts of therapy? Just a bit about clinical prevention trials, if you're going to set these up. I think the 2 difficulties are, first of all, you've got to extract the subjects from a population, and you're looking at small numbers in a very large population. And then you're moving on to clinical diabetes, where there is this high individual variation as to the expression of this immune process. So the rate of progression to clinical onset in prevention stage and C-peptide loss after onset is very, very variable, and there is no identification of personalized biomarkers. Where are we with the studies? Well, I'd like you to concentrate first on the green box. No study has confirmed long-term reduction in clinical diabetes in phase 3 studies, even if C-peptide preservation was seen in phase 2 studies. And that's what you have to tell families. there's a lot of excitement. There was a lot of excitement originally about oral insulin tolerization, and that has really proved to be, once it moved from the preclinical stage 1 into the stage 2 studies, has really shown no effect. From the point of view of biologicals, I think the one that people have really got excited about recently is Lumzab, the anti-CD3 monoclonal, and it's gone through stages 1. It's been used in stages 1, 2, and 3, only though in phase 1 and 2 studies. Now, there was a big excitement at the end of last year. They got some really exciting data on C-peptide preservation in their studies. But again, it's a phase 2 study, and they have not moved on to phase 3. And there's some discussion about dosing around that at the present time, and where they will take that. It will be set up in the future, but it's going to take a long time to get the answer. And in a sense, although that's exciting, it's delayed the onset of diabetes by a considerable margin, by around 20%, and it's increased the C-peptide preservation. But we will have to be patient and wait for the proper studies to be conducted, and they're going to take a while, because you want to know, if you start somebody off on this, is it going to make any difference? They're also going to try and set up a study on stage 3 patients in relation to this. Whether it will be effective, we don't know, and we'll have to wait and see. The other one that's been around a bit is Diamid and Gad-Alum vaccine. Again, that is not really looking very hopeful again as it moves into out of its proof of concept studies. And again, it's only being used in phase 2 patients, not in diabetes onset. Where it might be more interesting, and certain groups are looking at this now, is the combination therapies of different forms of immune therapy, or as Dr. Patney mentioned, combination therapies with biologics and beta cell preservation, such as the IGL-2 inhibitors. So that's really quite interesting, and there'll be some studies out over the next few years coming out of that. Just a point on who's organising all this. Well, it's got to be through large national and international trials organisations, and I've just put up a few of them. I'd be interested to know whether India has considered setting these up, given your population size. But you've got TrialNet, you've got the Immune Tolerance Network in the UK, in the USA, you've got Immune Tolerance Consortium in the UK, and you've got Inodia mostly throughout Europe. So these are exciting ventures trying to overcome the difficulties in setting up clinical trials in these various different therapeutics. So phase 3 trials, checkered history, questions the predictive value of animal models of phase 2 study. And I think there's a trend more to combination therapy and adjunct therapy. Immunotherapy, I think probably logistically and logically will be most effective in pre-stage 1 and stage 2. You've got to think about safety, you've got to have national screening programs, and you've got to identify the risk population. So that was a whiz through immune therapy from a clinician's perspective. Thanks for listening. I'd be interested in any comments. Thank you.
Thank you, Dr. Green. It was indeed very, very interesting and intriguing at the same time to understand about the immunotherapy when we talk about diabetes, management and treatment both, and prevention, of course, that's what you were talking about. Maybe once we are done with the last speaker of today's session, we'll take up a little discussion and interaction. Dr. Rupam, can we request you to introduce our next speaker, please?
Yeah, for the next talk, we have Miss Jess Sethi. She is from Ahmedabad, and she'll be talking about the type 1 diabetic empowerment. So she will talk about how empathy and educating those type 1 diabetic really helps in their diabetes management. There are many things to talk about Jess, but then that information I have, she has been working since a decade with the type 1 diabetic patients, and it has been a great handholding and a lot of educational thing which is going on in type 1 diabetic patients with the help of Jess. So I would like to welcome Jess for her presentation now.
Thank you. Thank you so much. And a big thank you to the entire committee for the invite. It's always a pleasure and an honor to speak at Diabetes India. And yes, today I'm going to be sort of getting in a little bit of a patient perspective when it comes to type 1 diabetes. I am someone who's living with type 1 diabetes. I've been living with it for the past 13 years. And today I'm going to talk a little bit about the work we do around education and empathy and how it really facilitates empowerment for those with the condition. So I'm going to just share my screen. I hope you can see it.
Yes, dear.
Okay, perfect. Right. So yes, like I said, that this is going to be my topic for the day, type 1 diabetes empowerment, how it's mainly about education and of course with a little empathy. So I always like to say that the diagnosis of type 1 diabetes is like a sapling that is withering a storm. So like a little sapling that's growing and it's growing, it doesn't know what's hit it, and it's come in the middle of a storm. And the sapling is sort of bending and it's withering and it might have lost a few leaves. And what does it need to actually start going back into blooming? It requires a little stick to support it back up. It requires some rain and some sunshine, and it requires lots of love and attention. And that is the way that the sapling can actually bloom into a tree. And this is very similar to what we go through when we are diagnosed with type 1 diabetes. And a little bit of my story, right? So I was diagnosed when I was 13 years old. And at diagnosis, there is the feeling of shock and fear, confusion, anger, frustration, loneliness, and denial. And I feel anyone who gets diagnosed with a chronic condition like type 1 diabetes when they're so young goes through this array of emotion. And at this moment, what we really require, this is when that sapling is right in the middle of the storm. And what we require at this moment is honestly for just someone to say, you're going to be okay. But unfortunately, our healthcare system is designed in a way where at this crucial and vulnerable time, we are given a lot of just numbers and doses, and you have to do this and you have to do that, and we're given eventualities and worst case scenarios, and it makes the person living with the condition take a step back and actually be very afraid. So at this moment of diagnosis and in the initial few years, what is very important is education and empathy. And when I say education and empathy, I always try to get the balance between the science and the soul, the science and the sensitivity. And a lot of us were not, unfortunately, given that when we were diagnosed. We were just given a prescriptive list of things that we had to do. And while that was okay, there's a very big difference, I feel, about living with type 1 diabetes and staying alive with type 1 diabetes. And that's what I'm going to sort of, go into. So when I say education, it has to be person-centered. It is not just about the patient. And I always say that we really try and talk about seeing the person behind the patient. So that means that when you're talking about doses, you're also talking about how you can manage your life with those doses. When you're talking about carb counting, you're also talking about, hey, you can actually eat everything when you are a person with type 1. You just need to figure out how to match your carbs with your insulin. So that's what I mean when I say not just staying alive with type 1 diabetes, because the staying alive bit is actually quite easy. It's about taking your insulin on time and monitoring and doing your diet and your carb counting. But living with type 1 diabetes is about how do you try to fit type 1 diabetes into your schedule and not the other way around. It's not about fitting your life into type 1 diabetes. It's about fitting type 1 diabetes into your life. So that's the kind of bit. And a few of the offerings from the Diabetes Foundation, what we work from is really sort of getting into that person-centered bit. So it's about getting very normal comic books out and handbooks that people living with the condition and their caregivers can use and utilize to understand that it's going to be okay and how you can manage this condition in your daily life. When I talk about empathy, there's a lot of work that we do on peer support, because I truly believe that that is very crucial when you're diagnosed with a chronic condition, because when you are diagnosed, it also brings upon a very overwhelming sense of loneliness, that you're often the only one in school injecting, you're often the only one in your dance class who will be taking insulin. So you don't feel it, but it takes a while for you to realize that I'm the odd one out. And peer support really breaks that. It gives you the confidence when suddenly you meet someone just like you. You not only listen to them, you not only learn from them, but you feel like you're not the only one dealing with this condition. And that brings such a huge sense of confidence and such a huge sense of camaraderie. And that also really improves outcomes we've seen. So peer support is such an important thing. And I would recommend and request all the healthcare professionals who are listening to this talk to sort of open up the network for their patients to other patient organizations where they can meet others like them. Language matters. Again, a huge thing that we talk about is because when you're talking about type 1 diabetes, the language you use can actually can sort of help get better outcomes. So when we don't try to use words like non-compliant or non-adherent or a person suffering from diabetes, we try to normalize it. We try to make it seem a lot more supportive and empathetic. So we've done a lot of publications, and you guys can check it out. But our offerings, like I said, from Diabesties, is the Language Matters document. It's available on the website now. You can see it, and a lot of work on peer support. So if you have any patients and they want to reach out, please sort of let them do. But today, what I really want to speak about is the marriage of both education and empathy when it comes together. One of the projects I want to really speak about is something called Back to Basics. So I truly believe that if you do not know the basics of type 1 diabetes, the fundamentals, you really will not be able to get into all the advanced things that we talk about, like closed loop and artificial pancreas system. The fundamentals are so important, and often those are the ones that are lacking the most. So one of our projects is called B2B, Back to Basics. It's an education and support project by Diabesties. And you can schedule a session with people from our team and get that diabetes management knowledge, counseling, or just a fun chat. So who is in this B2B team? It is healthcare professionals, dietitians, certified diabetes educators, psychologists, caregivers. But the main bit over here is that these are all people who are actually living with the condition. So we started actually in lockdown because we understood that people were getting very anxious about their management. And over the last 2 years, we have scheduled over 750 B2B calls. I want to share a little data from the research we have done after the B2B calls and show you a bit of the clinical and quality of life improvements that we've seen post these sessions. So just in general insights, what we could figure out is that lived experience of trainers gives participants hope, courage, and confidence. People thought that there was better suggestions on device management. Participants find it easy to trust trainers, as trainers have nothing to gain monetarily from B2B. Many feel that trainers' advices are more practical as they come from experience, and participants felt that they may understand some things that a few doctors may not be able to relate to. And many found that they learned practical and technical theoretical things like ISF, ICR, carb counting, injection technique, and things like that from the sessions. So the participant profile is that maximum of our persons with diabetes that schedule these sessions come from low and middle income groups, and around 55% of them were not using any tech as well. You can see the income breakup over here. And their understanding of type 1 diabetes management pre-B2B sessions was, as you can see, over 70% had none to very minimal understanding about type 1 diabetes management. And now I want to show you some of the pre and post data. So as you can see that pre-B2B and post-B2B, we got more people into the 6 to 7 HbA1c range. So you could see a cumulative drop in A1c post-B2B session. And it's not rocket science. It's basically because they understood how to manage their condition more. Also, frequency of hypers pre and post-B2B. We able to understand how to manage their conditions. So it's very easy to schedule a session for B2B. You just have to WhatsApp B2B to a helpline number. We just get your basic understanding, like, your name, your preferred language, your preferred time slot, and we cross-reference you to a trainer who can help you out, sit with you, talk to you. Topics that are included in B2B are things like diabetes distress, basics, management, things like that. So we also do physical B2Bs that can help really, because I think the basic thing over here is getting somebody to sit with you for hours and talk to you and make you feel heard. So I always want to say that it's a collaborative effort between healthcare professionals and persons with diabetes, right? So we are not doctors. We will never prescribe the insulin. We don't understand that science. You do understand it. And we are never, ever going to compete with you. But what we want to do is assist you, because we understand, as people living with the condition, as patient advocates, we understand that the healthcare system is overburdened, right? So we want to be able to ease that burden. So you prescribe the insulin, you prescribe the science, you take care of the physiology bit, and let us take care of the entire education bit. That way, the person who is diagnosed with the condition gets the best of both worlds. Because I truly believe that it's not either or. It's not either a scientific consult or lived experience. It should be both and. It should be both. You survive and thrive with type 1 diabetes. And as patient advocates and as organizations, we want to be able to support the doctors and healthcare professionals to make it as easy as possible. Because I truly believe that we rise by lifting others. Thank you so much. And I'm happy to take questions as well.
Wonderful and amazing work you're doing over there, Jazz. And let's open the session for a couple of questions. I suppose Dr. Green wanted to ask a question to Dr. Patni in the start. And can we start with there, please?
Well, actually, right, okay. I was going to ask another question.
All right, okay.
Can I ask to Jazz? Fabulous presentation. Thank you very much. And also to Barkai. And to Dr. Pathia, in a way. So the frustration is that the new technology is there. Theoretically and in clinical trials, it works much better. There's no doubt about that. But when you put it into the free living person with diabetes, out into the community, it doesn't work as well as we think it should do, and people stop using it and so on. Now, we went through this when we changed to multiple daily injection therapy, and over the period of 15, 20 years of just using multiple injection therapy, people began to realize that what Jazz was saying is actually a key to it. And in fact, it was already there in the DCCT, that if you don't support people with their treatment, they won't get the best of it. And I just wonder, from all of your experiences, both from a personal person with diabetes and so on, is the problem we've got at the moment with diabetes technology, we think the technology is all that you have to do, and we forget about the support side of it, and that's why we're not doing very well with it. I mean, it's an open-ended question, and we could go on for years about this, but I just throw it open as that.
Yes.
Yeah, I mean.
Sorry. Okay.
Sorry, go ahead.
Okay. The answer is yours, please. Okay, I give you.
Okay, thank you. No, I just want to give a little bit of personal experience over here. So I got onto an insulin pump many years ago, and then I started looping just 2 years ago. The amount of support I got from the looping community was far greater than what I got when I got onto a pump and a CGM earlier on, just because it was the we are not waiting patient movement. So I reached out to a lot of colleagues of mine who were looping as well, and I got a lot of support. And I think my sort of success with looping is far greater than it was just when I was on a pump. So I think what happens, at least over here, and I've seen this time and again, is we give people technology and ask them to figure it out themselves. We teach them just the basics, but having the support of how to integrate that into your life, how to actually work with it, how to troubleshoot with it, is not done enough. So, and I feel like that gives a misconception to people, saying that a pump is a cure, when it's really not, right? So it's about sort of making the most of it. And technology without education just doesn't work. It will not work, and people will have to resort back. So I think it has to be technology with getting people of lived experience to help out, train, mentor, guide, so much so that they can actually integrate it into their lives. That's what I feel, at least. And that's what, with my experience, has also proven to be true.
Yes, I totally agree with these comments, of course, of Stephen's comments and yours also. My personal experience as a medical professional is also the same. As the first step, probably we are failing to pick up properly those patients who are appropriate for the treatment, I think. And if we provide these new technologies for those patients who are not really motivated, who has a lack of education, the environment, socioeconomic environment, and so on, family attitudes. So we will not able to get much better results using this pump and CGM as compared to the multiple daily dose insulin. So, and if we do in such a way, we will face with the problem that, okay, the patient is coming back to our office and saying that, hey, doctor, it's not working. The result is not better than previously. So I think this is also a huge area, not just the pathophysiology, not just the physiological approach, but these education, as you mentioned, and the motivation of the patients and best pick up best prediction how these devices are working well. Yeah.
Excellent. Dr. Dhruvi, I think we are running already late. So do you have any question in chat box? Or?
There aren't any questions in the chat box, but I think Dr. Green wants to make a comment.
I was just going to ask Dr. Pathi the question I was going to ask him when he was talking. Sorry, very briefly. I mean, yeah, you're right. We've got to think a little broader than insulin, haven't we? In terms of treating diabetes, is there an issue in India, particularly about insulin availability? Is that a problem, or is it something which you feel fairly reasonable about?
I don't think there's a problem right now. There's no more a problem as far as insulin availability is concerned. But I think what is more important, what Dr. Bakai said as well, and what Jess said, basically it is the hands-on or the practicality of education, which is more important. If you really have to use your whatever innovation you wish to use or the tech, it's more the practical aspect which goes into rather than the they may be illiterate, but they will be able to grasp the tech much more easier if the practical approach is there. And I think she's doing a great job, and that's how it should run.
Okay.
Well, we've had a wonderful session, and like Dr. Chaudhary just suggested that we are a little late and out of our time. Can we have just one closing remark from each of our, respectable speakers over here? Can we start with Dr. Patni?
Thank you, Dhruvi, first and foremost. And obviously, as my talk was on adjuvant therapy, and Stephen had given us a great view of the various stages and what therapy can be utilized on those stages. The only problem with the identifying of the stages is not going to help. Even if you identify whether you will be able to supplement the therapy then and there, that will be difficult. So acting fast and acting appropriately will be required. So identifying the pre-stage 1 will be very difficult. I think you will agree, Dr. Stephen.
Thank you, Dr. Patni. Dr. Laszlo, you want to give any remarks, one line or something?
Thank you very much. I was really happy to be here, and I enjoyed all of the speakers, all of the topics, and I learned a lot. Thank you very much. Thanks.
Thank you, Dr. Barkai. Dr. Green?
Well, thanks very much. Yeah, nice to meet people back in India again. Yeah, you sit here for an hour and a half and you start thinking about things, which is quite good. And so I'm beginning to think about different things now, which is really quite nice. And I really enjoyed the talks. Thank you very much. And regards to all the people in India that I know. Thank you. Bye-bye.
Okay. Jazz?
No, thank you so much. It was an honor to be here with such esteemed panelists, and just very big thank you for the invite as well.
Thank you so much. So thank you to my co-chairperson. Thank you to all our esteemed speakers. We really had a wonderful and a very fantastic presentations. Yes, Dr. Green.
One more thank you to the technical people. It's fantastic.
Yes, thank you.
Wonderful. Well done. Well organized. Fantastic.